Hello, everyone. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'm delighted to welcome you to today's webinar. For those of you who may not know the Primary Care Collaborative, we're a national organization that convenes stakeholders from across the healthcare landscape who are committed to improving the nation's health by strengthening primary care. I'm very excited to welcome you to today's webinar entitled CMS Draft Regulations, Modernizing and Improving Pay for Primary Care in Medicare. And we're thrilled to have so many leading voices from across the healthcare landscape here with us today to provide their thoughts and reactions to this proposed regulation, which we'll be discussing. And we have some asks for all of you who have joined us, and you're going to hear these a couple of times. We're going to ask that you respond to this draft rule. Responses are due by September 12th. We're going to ask that you tap the shoulder of your colleagues to ask them to respond to this rule. And also that you send us your comment letters, and we'll provide an email address so you can do so. We'll be talking a lot about why it's so important for the primary care community to respond to this draft regulation. I also wanted to let you know that we have a guide which lays out all of the major primary care provisions in the 1,800-page draft rule. It details the implications, and then it suggests what folks may want to comment on relative to that provision. I want to thank Larry McNeely in particular and Todd Didier for developing this. You will have this, so you don't have to be writing things down as you're listening to this webinar. You'll have this as a resource to inform you going forward. A couple of housekeeping items quickly before we get started. This session, like all of PCC's webinars, is being recorded. We make the recordings and any slides available within 24 to 48 hours on our website. You can then share this with your colleagues. We'll be actually not taking questions today because we have such a jam-packed agenda. But feel free to follow up with us about your questions, particularly as you consider how you're going to respond to this rule. We are very committed to delivering high-quality webinars and exploring really important topics to the primary care community. So we'd appreciate if you take a minute or two after the webinar to fill out the survey. Let us know what you thought about the webinar and also give us additional ideas. I apologize for my voice. I do not have COVID. I've got some sort of summer cold, and I think it's going to hold up for the hour, but please forgive me for the sort of hoarseness that you're hearing. Okay, let me welcome Asaf Batan. Asaf and I are going to have a conversation about some of the major provisions in the rule, and then we're going to ask leaders from across the healthcare landscape to give us their views on the rule and why they think it's important to their particular constituency. Wonderful to see you, Asaf. For those of you who may not know Asaf, Dr. Batan, he's an internist and he's executive director of Ariadne Labs. Ariadne Labs does a lot of innovation work, both in primary care and elsewhere, nationally and internationally. He is also at Brigham and Women's Hospital, where he's works as a health systems innovator and has an affiliation with the Harvard Chan School of Public Health. Also, finally, he's currently serving, he's got many different titles, but this one is important. He's currently serving on the NASM Primary Care Standing Committee, where he chairs the Payment Committee. So let's get started. I think this proposed rule really reflects the thinking of so many folks from and it really is bipartisan. We've got folks from the Biden administration, the Trump administration, and they are all committed to modernizing and reforming the fee schedule. We also know that we've had a lot of contributors outside of government, including the NASM Standing Committee on Primary Care, Many other researchers and analysts from across the spectrum, among them Bob Berenson, MyFam, and many others, along with the members of the PCC. There are many ideas that have come through our membership and have informed this rule. We're also very pleased that the PCC was tapped to contribute to these ideas. So I think what I just want to leave you with is this really represents a lot of important thinking across the primary care community. My own observations about the impactful provisions for primary care include the following. We're very excited to see that this proposed rule, builds on a bundled payment for primary care, the APCM, which is a monthly payment that is not, primary care clinicians are not required to record their time when they are billing for this code. They go through a process and to be identified as meeting the requirements, and then they get a monthly payment. So what we have in this rule is the APCM, which was introduced in last year's rule, a bundle payment to take care of a lot of things that primary care either does not get paid for now, or the codes that we have are too administratively burdensome, and so many practitioners don't bill for them. We're hoping to incent that activity and remove the administrative burden. What this rule does is add behavioral health integration to the APCM. So that's very exciting. It's a recognition of the importance of behavioral health integration as a critical part of comprehensive primary care. Another, I think, really important dimension in this rule are provisions that rebalance pay between primary care and specialists. And we'll talk more about this notion, the efficiency adjustment. And it is critical that we do this rebalancing. Primary care has been losing relative to other specialties, and that has a dramatic effect on the availability of the workforce, those selecting to go into primary care, and also access to primary care. So how we pay and how much we pay has real implications for the kind of care we all can receive. Another important thing in the rule is consideration for additional data sources beyond surveys, really getting to leveraging empiric data, and we'll have the opportunity to talk more about that. So let's get started by also asking Asaf to reflect. You've been able to cross administrations building and have witnessed yourself. You've had a front row seat to how they've been building on previous ideas. Discuss a little bit more, Asaf, what you see as a continuation in the rule and what you see as brand new and what excites you.
Well, thanks so much, Anne, and it's great to be here with you and with 300 plus of you or more online. So the perspective that I'm going to be bringing is that of primary care physician and practice at a community practice associated with a system. It's as a health systems researcher. I do have to tell you all that I'm a part-time senior advisor and have been for the last 13 years to the Center for Medicare and Medicaid Innovation. I'm not speaking for them at all, and really all my comments really come from my work, in the system of clinical care and research around it. But to your question, I think that what we're seeing in this rule and what's been proposed is really falls under three areas around sort of continuing a shift that's been over a decade in the making across CMS and federal and in many cases state Medicaid payment initiatives to change overall, gradually speaking, the ways that primary care gets paid in terms of the form, a slow but steady shift away from fee-for-service toward non-visit based payment. The level, a steady, modest, but notable gain in the level of resources, or at least some types of payment that are oriented toward primary care, and some early mechanisms to track the flow of, or to try to aim payment initiatives, value-based payment initiatives, to make sure that they actually reach primary care practices and clinical teams that are on the front lines of care. Now, I should say that despite those laudable goals to change the form, level, and flow of payments, the reality still remains that primary care is underfunded, and that the proportional share of whether we look at Medicare funding or commercial insurance is actually falling. So the proportion of total healthcare spend that goes to primary care continues to gradually fall, despite important efforts that we see, like in the fee schedule, to change that. Now, for this year's fee schedule, I think, and we should delve into the details as well as with the panelists. There are also three areas that you alluded to, and the way that I bucket them is really the how, the what, and the where of primary care payment. The how that I think we all might want to focus on, and again, is building on last year's rule and previous work, is a real look at how the mechanisms around the RBRVS system, the system that sort of weighs the RVU payments for a variety of services. We're seeing a gradual shift in the mechanisms of data input. CMS has indicated in terms of requests for information, and then in this proposed rule, an interest in adding to the sources of information that they use to value services comparatively. Remember, according to OBRA 1989 Act, CMS has to have a apples to apples comparison so that they can pay for services under the physician fee schedule and be able to pay for things as disparate as a cataract operation and a complex consultation for someone in primary care. And in order to do that, they have to have a comparable system of work units. And previously, what we have seen and what many journalists and scholars have highlighted is that CMS has generally relied on a committee's called the RUC's evaluation of those units and recommendations, and taken up about 90% of those recommendations as their own. But what this year's rule is starting to suggest is an interest in a variety of mechanisms, a variety of data sources to look at how services are comparatively valued. And that's important. That's not just in the weed stuff, because the RUC has a comparative mechanism. They survey each of their specialty provider groups, and they get response rates from physicians in practice in these various specialty societies. But those surveys, as indicated in this year's proposed fee schedule, the survey response rates are rather low, and there's some questions about how broadly representative those survey responses are. So what CMS is saying in the how part of payment is we CMS wish or they wish to see a broader set of data, different types of data, time and motion studies, et cetera, that allow them to perhaps more effectively value complex services like those that we see in advanced team-based primary care. The other how difference is, as you talked about, this efficiency adjustment, and the efficiency adjustment really proposes to set in markers that say, most procedural services practitioners get better and more efficient over time with. And so CMS is proposing to apply downward adjustment to those components of Medicare payment, but they specifically exclude any downward adjustment on time-based services, which happen to be those that primary care and others rely on in evaluation and management and sort of cognitive interpretation and sort of relational care of patients. So this adjustment could start to rebalance some of the shifts that we've seen in Medicare payments, slightly away from technical procedural codes toward time-based relational primary care codes. In the second group, so we talked about the how, now the what. You mentioned the APCM, the Advanced Primary Care Management codes, and these really offer a new way for Medicare to pay non-visit based payments to primary care clinics and teams without an undue burden of high documentation, but with certain set parameters and assumed capacities, 24/7 access, team-based care, proactive outreach to patients. And so what this year's revisions or proposed revisions do is add to that suite of chronic care and transitional care bundles and management codes that have been bundled into one, and add a behavioral health integration component to try to pay for teams to care for the behavioral health component. And so this expands a little bit the sort of scope of services that are meant to be covered under that non-visit based bundle services to kind of get us away from fee-for-service. And in the final bucket, we've talked about the how, we've talked about the what, and now in the where, CMS is really saying that it's going to sort of flip a little bit what has been, practices that have a site of care that are associated with hospital-based systems, get a facility-based adjustment, and they're proposing to reallocate some of that existing indirect practice expense to shift it toward more community-based as opposed to hospital-based practices. So, this how, what, and where kind of complements a change over the last decade of form, level, and flow.
I really appreciate your categorization and your analytic frame to help us think about some pretty important draft regulations. There's been this reliance on the interviews for the surveys for a very long time, and I think the community who has additional ideas about how CMS can move forward would be well served to send those ideas in. In addition, some analysts are talking about having the CMMI or the CMS Innovation Center use some of their resources to be innovating in this area. I mean, that really is our sandbox for primary care, or not primary care, payment and delivery reform writ large. And so it would seem to me that could be a place where some of this innovation could take place. We certainly have a lot of electronic records data. We certainly have a lot of data from surgical suites. We certainly have a lot of data to augment what we currently have. And I think that is important as a way to modernize such a critical component of our healthcare system. For those of you who perhaps are not waking up every morning thinking about payment, what Medicare does really sets the table for the entire healthcare system. All the other payers key off of Medicare. So that's why it's also so critical to get this right. This site of care provision, most of primary care now is working in hospital-based arrangements for an insurance company or for organizations that maybe are private equity backed. You can argue whether or not those are independent or not, but they're working in different kinds of arrangements. Do you have a view on how this site of care provision might change things? I mean, I'm just curious what you think about that.
Well, it's a potentially important adjustment from the past. And again, not speaking at all for CMS, but really as an observer and as a practicing clinician, historically, these indirect practice expense reimbursement adjustments have been higher for, again, what are termed facility-based practices. And facility-based practices are not just to be clear, those that are literally located on the main campus of a hospital. They certainly include those practices, but in many systems, not all, but in many systems, they also can include satellite clinics that are owned and operated by, let's say, the main health system or hospital system. And so the hospital system sort of is able to bill for a facility fee as a part of that ownership. And what this proposed rule suggests is that it would reduce this allocation to half the amount of non-facility based practice expense RVUs beginning in CY26. And that, I think you make you always make great points, Anne, but there are two really salient points that you just made. Number one, in a rapid shift, I mean, in a decade, we've seen from low double digits to over half of practices and more owned, and more than 70% of primary care clinicians are affiliated, salaried plus. And so, this may potentially impact those that are not. They'll get sort of higher payments in non-owned, non-affiliated practices, but for the majority that are, this may have potential unintended consequences downstream for some of these owned practices. Again, CMS always seeks comments on these, and they are proposed rules because they seek the community's comments on intended, unintended, and potential consequences. And so I think that should people on the call be, have a perspective, I think the key message here is to think through and read, maybe not all 1,800 pages, but the relevant pages for primary care or for your practice or for your network, and think through some of those implications, bearing in mind, and we sort of alluded to this earlier, that a lot of what happens to primary care is not under primary care clinicians' control. So both the good and the bad, meaning that, many primary care clinicians are in ACO arrangements, and supposedly they should be getting benefits from more focus and payments and aligned revenue for population-based care and community outcomes aligned to global targets. But the reality that we know in practice is that many primary care clinicians may be part of an ACO arrangement, but still get paid under what some people would call like a shadow fee-for-service billing arrangement that's really not aligned to the core goals and the core operating procedures of what the ACO models intend. In the same way, it might be the case that many primary care practices might be in facility-based arrangements in which some of those RVUs now are lost, but will they feel that difference, or will they take the hit? Will their systems pass on that revenue loss, but not pass on the revenue gains of other areas? Well, that remains to be seen, and that we should look at very closely.
Well, thanks so much. And there are provisions in the rule related to ACOs and an RFI related to ACOs. So that we'll just put that in the parking lot for now. Let me welcome our panelists who are leaders across the landscape, as I mentioned. First, I'd like to welcome Sherry Erickson. Those of you who have been hanging around PCC know Sherry well. She's Chief Advocacy Officer and Senior Vice President, Government Affairs and Public Policy from the American College of Physicians, where she oversees advocacy and policy for one of the nation's leading clinical societies. Great to see you, Sherry. Next, I'd like to welcome Daniel Escobar, who's Director of Public Policy at Humana, where he focuses on primary care, value-based care, and health IT issues. Welcome, Daniel. Next up, Darren Fogarty. He's Associate Director of Purchaser Value and Policy at the Purchaser Business Group on Health, which is a nonprofit coalition of jumbo employers and public entities who collectively purchase $350 billion in healthcare annually for 21 million Americans. That's a big number. And last but not least, I'd like to welcome Sophia Tripoli, who is the Senior Director of Health Policy at Families USA, where she oversees and leads Family USA's strategic development and framework and all aspects of healthcare priorities. And I don't see Sophia yet, but hopefully she'll be joining us momentarily. So first, there you are, Sophia. Lovely to see you. Welcome. All right. So first, reflecting on the conversation that Asaf and I had and the broader rule, why does any of this matter from your perspective? What do you think the impact will be on, or the potential impact on patients, the delivery system, and the group that you're a part of, your own constituency? Who would like to start off? Sophia, why don't you get us started?
Sure, happy to. And first, just want to say thank you so much to Anne and PCC for organizing this webinar. It's such an important conversation and great discussion between you two to get us going. And nice to see everybody virtually as well. I think there's so much to say here, so I'll be brief because I want to make sure we have time to hear from everybody on this. But I think from the patient and consumer perspective, this really matters. I think a lot of patients and consumers don't know or don't understand that the way that we shape payment in healthcare and in Medicare in particularly sets the signal, I think, and as you mentioned, for payers across the healthcare system, the design of what we pay for, what we don't pay for, whether we're paying on a fee-for-service basis, whether we're bundling services together to reduce administrative burden for providers, is so important to making sure that patients and consumers actually can access the care they need at a price they can afford. And so a lot of the changes that we're seeing in this proposed rule are things that patients and consumers have been advocating for a long time, particularly around primary care, revaluing a lot of the services, making sure that primary care providers have reduced administrative burden, that they are paid for the things that they are actually doing, that we know drive improvements in health outcomes for consumers. The rule's not everything, and there are some places where we need to make sure that we've got some good feedback and conversation going with the administration. But there is a lot of really positive steps here from the consumer patient perspective on primary care payment.
Thanks so much, Sophia, from the consumer perspective. Why don't we go for those who are actually writing the checks? Darren, can you reflect on the rule?
Yeah, absolutely. And thanks for inviting us to be part of this conversation. It's an honor to be among such an esteemed group here, discussing PBGH's #1 priority, which is advanced primary care. As Anne mentioned, I'm representing Purchaser Business Group on Health. Our members, who are among the largest public and private purchasers of healthcare in the US, many of whom are deeply invested in prioritizing and supporting primary care. As healthcare costs continue to rise at near double digits for, I think, the third consecutive year, our employer members are looking for ways to lower their costs without diminishing the quality of their healthcare benefits. They seek options to do so in part because they are facing unbelievable pressure as fiduciaries to prudently purchase cost-effective, high-quality healthcare for employees. We know that one way to do this and accomplish these objectives simultaneously is advanced primary care. In fact, it's one of the only solutions that we know of that lowers costs and improves employee health and well-being. And it's on this basis that our members have made it their #1 priority. To answer your question, why is the MPFS rule important for employers? The answer from my point of view is because the policies that CMS applies to the Medicare program are clearly quite consequential for the commercial market in two ways. #1, a research paper from 2017, one of my favorite titles, called "In the Shadow of a Giant," carefully documents Medicare's influence on private healthcare payments, so the two are directly linked. And #2, the investment and practice decisions that health systems and physician groups make often depend in large part on the policies of public payers. So suffice to say that although the CY 2026 MPFS rule is undoubtedly esoteric, it matters a great deal what CMS does or does not do and what employers have to say about it. We, for our part, are greatly encouraged by the proposals in this year's fee schedule. I've spoken with some members on my team who are working directly supporting primary care physician practices in California. They are particularly enthusiastic about CMS's support for and attention on the need for behavioral health integration and the collaborative care model. our employer members want this kind of care for their employees. Some of our employers are frustrated by the lack of responsiveness from the healthcare industry in providing high-quality advanced primary care. They have forged ahead in building their own advanced primary care networks based in part on performance standards that they've identified with PBGH and put forward as expectations and signals for the marketplace. These employers are saving 7 to 14% on the total cost of care for their employees, which is significant, especially since these programs also have a quite high net promoter score of over 70. To the degree the federal government is rowing in the same direction on these rules, we are very supportive of that. And we encourage other employers and employer groups who support primary care to show their support as well. That's how I would have to say about it at the onset.
Well, it is really gratifying to hear that it is your number one priority. And if we can get alignment with the with public and private payers to support primary care, I think that will go a long way. Very exciting to hear that. Sherry, you are in constant conversation with the folks that you represent, but also many other primary care clinician organizations who are digging into the detail of these rules. And I'm sure there's a lot that, needs further massaging, and there are things that you all will be commenting on to help improve the rule. But at a higher elevation, can you describe a little bit about, how you're thinking about this rule?
Sure. Yeah. Thanks, Anne. Thanks for having me on this webinar. I really appreciate the opportunity. And so ACP represents, or the American College of Physicians represents 162,000 internal medicine physicians across the country and as well as internationally. And so we have a very deep and interest in this rule and what comes out of it. All of our members in the US are certainly impacted by the physician fee schedule every single year. And so this rule in particular, given that ACP, we represent a number of physicians that are in primary care. In fact, I think internal medicine provides a significant amount of primary care across the country. But it's about a third of our membership. We also have a third of our members providing hospital-based care, hospitalists that are out there providing that type of general internal medicine to hospital patients when they are in the hospital. And then also another third of our members are subspecialists in internal medicine, some of whom are more procedural based, but some of whom are not as focused on procedures. And for example, infectious disease is one solid example that is impacted by the rule. But with all of that said, we've been involved with the Primary Care Collaborative since its inception and believe very strongly in the need for a strong primary care basis in this country. It is what has shown to have the best outcomes and reduce cost for patients and for the system as a whole. And so therefore, overall, we've been supportive of what is in this rule and what it does for primary care. I do think that there are nuances that really need to be considered within here. Particularly, I think with regard to what Dr. Baton was talking about with the where in terms of the facility-based piece. And that is that cutting the PE in half, the PE RVU, relative value unit, in half for facility-based practices. And that offers a number of challenges that we need to think through. One of which I worry about the most is the impact on rural hospitals, who are already being impacted by the Medicaid cuts. So I do think that's something to think about in your comments, even though overall the intent is really good to try to move towards these ambulatory-based care practices. The other thing I will say is that, and I mentioned infectious disease, that's critical, obviously, right now, given we're coming into RSV season and flu season and COVID, and obviously that will continue into the new year when these would become effective, should they be finalized, and so because most of them are facility based, they are impacted pretty significantly by what's proposed in the rules. So I think there are just some nuances we need to think about with regard to what's in there, particularly with regard to the PE adjustments. But I think that given that, plus the efficiency adjustment, as well as the APCM changes that have been proposed, it certainly looks like it would benefit primary care as a whole. I'll stop there.
Super. Thanks so much, Sherry. And I know we'll come back to some additional questions. Daniel, we'd love to hear from you with the health plan perspective.
Sure, absolutely. And again, just to echo my colleagues here, thank you so much for having us today and bringing this conversation forward. From a payer standpoint, similar to the points Darren raised, in many cases, this is really a reinforcement of our commitment to value-based care, that this is something we've been doing for quite a long time at Humana and remain very much focused on this as part of our larger mission. I think overall, just to put it very succinctly, something we see coming through very clearly in this rule is a newfound appreciation for who is owning the relationship with a patient in many cases. That especially in the advanced primary care management services, as we look at those, this is really an emphasis on who is managing that relationship over time and providing some investment in maintaining that relationship and maintaining that accessibility to the individual over time as well.
Well, thank you so much. And we do know that at least some of the kinds of things that are contained in the APCM are not currently paid for. And there are estimates that primary care overall performs services, 20 to 30% of what they're doing is not actually reflected in the fee schedule. So clearly, modernizing the fee schedule is very, very important. Why don't we talk a little bit about the APCM a bit more, and this broader notion of hybrid payment. I think those of you who have worked with the Primary Care Collaborative know that we have adopted the National Academy of Science, Engineering, and Medicine recommendation that we move towards hybrid payment, a mix of a prospective monthly payment along with some services that would still be paid fee for service. And we see this addition of behavioral health integration to the APCM as moving us down the path. Opening this up to the floor, would folks like to comment on how hybrid payment might transform primary care and the importance of moving down this road? The rule also suggests other services that might be added to the APCM down the road.
I can kick us off. PBGH's definition of advanced primary care has always included integrated behavioral health, so we completely agree with the focus on it. Untreated behavioral health needs can derail the potential that advanced primary care has and should be treated as a primary care need, whether it's appropriately handled in the primary care setting or is facilitated in a timely handoff to a more appropriate provider. The other thing I would say, second, from our perspective, the goal of moving away from fee-for-service and primary care toward hybrid models that include capitation is pretty central. The details of how that's done do matter. I understand one of the areas that CMS is considering in this rule is to shore up the program by lessening the administrative and documentation burden on providers associated with their time spent tracking patients' behavioral health needs. On its face, this is entirely consistent with us trying to get primary care practices to offer behavioral health services as a core part of their practice. I mentioned earlier, our employer members clearly care a lot about this being behavioral health being a part of the healthcare delivery system. The mental health and well-being of their workforce is top of mind coming out of the pandemic. We are supportive of CMS reducing the friction that primary care practices face in sustainably offering a robust suite of preventive care services that unfortunately have been traditionally underinvested in and underdelivered as a consequence. That includes, but certainly isn't limited to, behavioral health.
Thanks so much, Darren. The rule also. Oh yeah, sure. Go right ahead.
Just to pick up on that as well, the literature is very clear that fee-for-service or even augmented fee-for-service 10-20% bumps in RVUs mathematically cannot actually support the core capacities of what we mean and what we have defined as advanced team-based primary care. So I think that hybrid payment is a route in the absence of a health system or a health financing system that sort of shifts overnight to a radically different prospective, capitated, risk-adjusted payment. We all know that that's hard. It's hard for payers. It's actually hard for practices that have been built and set up and scheduled basically to be fee-for-service maximizing entities. And so hybrid offers a route to deal with the math. The math is very clear. No, even with these bumps, there isn't going to be a doubling of evaluation and management codes for primary care. So in the interim, what you can do is continue to bill fee for service, but start to build out from that chassis more substantive payments that aren't tied to an office visit with an E&M code, but are tied to the services and the goals and the alignment that Darren is talking about what the community and what patients want and need. And so there was a question in the chat about, well, what does it look like to move the flow of money to primary care? APCM is a lot of money. I mean, depending on the level of comorbid conditions, it's somewhere between, for the healthiest patients, $10 per patient per month. The middle tier is above $50. The highest tier is above $110 per person per month. And that's before some of these behavioral health adjustments kick in as proposed next year. So this is real money and real payment that can flow with reduced burden potentially to primary care practices to provide the kinds of services that Darren and others were just talking about.
I mean, if I could just pile on for 1 second to just say, I think, we have a real world application of what it looks like in primary care and behavioral health when we don't have a hybrid payment. And if folks remember from just a few years ago in the middle of the COVID pandemic, when volume crashed and dollars were no longer flowing because there were no longer in-person visits, you saw the sectors, the provider sectors, parts of the healthcare system that were reliant on fee-for-service, over-reliant on fee-for-service, nearly collapse. But you saw the parts of the healthcare system that had integrated value-based payments, that had integrated these alternative ways of paying and bundling services survive in a way that practices who had not done that really struggled, and many of them went out of business or had to be or ended up being bought up by larger systems that had the ability to help them keep their doors open. And so I think the hybrid payment is probably not the end goal in terms of primary care payment or just in terms of sustainable payment, but it is the right next step in terms of giving primary care and behavioral health a glide path into alternative ways of paying for healthcare that actually are going to better align the health and financial security of the patients with the business model of providing and paying for and delivering healthcare in the U.S. healthcare system.
Thanks for reminding us of the perils of fee-for-service, and also this notion of a monthly payment gives the clinician some more flexibility about how they want to deliver the care. That is not tied to one of the 9,000 codes that they need to record. I mean, I think having the ability to deliver care in different ways without being tied to a code, I think is really important in order to better be able to meet patient needs. I think there is a recognition in the rule that we've got some challenges with the current APCM in that beneficiaries, if they don't have coverage for additional costs within the Medicare program, have to pay a monthly copay. And so the rule suggests they open the door to think about how we might address this issue of beneficiary cost sharing. Would anybody like to unpack that a bit and consider what CMS is proposing and what you all think of it?
I mean, I'd love to kick that one off.
Okay.
This is what we've been asking from the beginning when they first proposed this code or these codes. So, the fact that they are now talking about the code itself or the services the bundle itself as already including preventive services or potentially layering in more preventive services to it is really encouraging because as you know, the preventive services that are determined so as A or B level preventive services do not have cost sharing associated with them for patients. And I will say from talking to my members who are out there trying to use those codes, that is one of the biggest challenges that they have faced is really talking with their patients about this sort of set of services and the fact that it's going to have a copay associated with them. Obviously, if they have some sort of supplemental, it may be less or not a copay. But with that said, that was one of the biggest hurdles some of my members faced in getting off the ground with it, and they continue to face. So having this bundle be include preventive services or be viewed as a preventive set of services would be a huge benefit for those for patients and for the physicians that are out there trying to provide this service, because that is, again, one of the biggest challenges they faced.
Yeah, and I'll just briefly add on to that. I think, one of the biggest barriers for consumers in accessing healthcare is rising costs. And costs have been rising for a long time, all different types of costs for all different stakeholders in the game, whether you're a public payer, private payer, or a consumer or on the other end. So I think this is definitely a moment, where this idea of individual, like having some skin in the game, some individual responsibility is coming up. But I would say the place for consumers and patients, this idea that you do that by shifting more cost into consumers is just a flawed approach. And I think that the more that consumers are faced with costs, the more the healthcare is eating up more and more of their monthly budgets. As more, the more that costs increase and employers have to absorb more of that and trade off wages, like that all has an impact on the consumer, and it's all driven from the total cost of rising healthcare and the way that shifts onto consumers and patients. So I think it's a big problem, but I do agree with Sherry just on her comments that this should be about reducing barriers to care and getting people the care that they need at a price they can afford. And the reality of where rising costs are in the system right now, consumers can't take too much more of it. More costs means less access to care. And that's the exact opposite effect that we need, particularly in primary care.
Thanks so much. We also know that it's administratively burdensome for the practice to have to ask for this copay, and that other codes like collaborative care code and TCM code that have a beneficiary copay, the uptake is not what many of us would hope. And I think some analysts suggest that is because of the one factor is the beneficiary copay. So we applaud ideas to try to address that, and encourage you to comment on that part of the rule. Let's talk for a moment about the efficiency adjustment and use of new data sources. Sherry, I know that you all have been having these conversations about new data sources and the importance of modernizing Medicare. I'm wondering if you want to kick off that conversation for us.
Happy to, Anne. Thank you. So ACP, like many other specialty societies, and I say specialty society because internal medicine is a specialty, although the good chunk of them are the ones providing primary care out there. We participate in the RUC process that Dr. Baton talked about, as do many others, and actually do believe it's an important component of the system in terms of the ability for physicians to provide input into how they're paid. With that said, we have been calling on the RUC and the AMA more broadly to modernize those approaches, really along the lines of what has been outlined in this rule. And CMS asked about this actually last year as well, and we provided input there. So they've been thinking about this for a little while. It is a real challenge to think through what are those right data sources, what data can we get from those sources like EHRs and metadata and all of that, and how can that then be weaved together with if we continue to do surveys, how that can work together to then determine relative values, which is another layer of complexity in the system. And on top of that, we have this budget neutrality issue, which is why, these changes tend to be so controversial because they are shifting money, from one set of specialties to another, because there's no sort of market basket update or inflationary update, or adjustment, when a lot of money moves within the fee schedule to help fix that. So it's a complex set of factors, but what I will say is that we have been really a proponent out there calling on the modernization of this process and having greater input into the process, greater transparency around the process, and then also really thinking through different options for data sources that could be more effective and informative. Because what I think, I can't remember which one of you said this, but it's very accurate. We certainly have had real challenges in getting meaningful response rates to the surveys for any of our codes over the past number of years, and so it's hard to feel great about that when that's what's happening out there, because the surveys are quite complex, and really what they end up happening is you end up getting data from large systems more so than necessarily smaller or independent practices, and even those that may be affiliated with a facility but are still kind of operating on their own largely. And so it's hard to say that the data is truly reflective of what's going on out there. So that's where we are on that, and are glad to see that CMS is really starting to listen to that plea for modernization around the process.
Asaf, is there anything you want to add? I know that the NASM Standing Committee looked at this issue in particular.
No, I think Sherry covered it well.
Great, thank you so much. Okay.
Add one piece. I'm sorry, Anne. I just
sure.
wanted to mention this because I think it's important both relative to the previous conversation and this one. And that is that one of the big wins we've had over the past few years is the implementation of the G2211 code, which again is still part of the fee-for-service system. So I recognize it has inherent challenges because of that. But one of the reasons why, it's challenging is because the CMS has overestimated the utilization of that code. And so when that happens, then that sort of excessive money that's associated with that code impacts the conversion factor and the fee schedule overall. It's where that money just sort of goes away, almost it leaks out, so to speak. And so that's something CMS unfortunately did not address in this rule. We are going to be asking them to consider it because it's not just G2211, although that is a big example. Even what you mentioned, and transitional care management, chronic care management. These are codes that have been long overestimated in their utilization, in part, I think, because of the copay issues, et cetera. But with that said, that's just something I wanted to mention because it is sort of another impact of the budget neutral system that we're dealing with, and that hopefully others will feel the need to comment on, even though it's unlikely CMS will do anything this year because it was not addressed in the proposed rule.
Thanks so much. There is an RFI, and there is conversation. There are provisions that lift up and request information and ideas for how the fee schedule might better foster whole person primary care. So, a more comprehensive set of services that tap into helping patients change their lifestyles, eat better, etc. I think when you consider the broader context for that, the Make America Healthy agenda focused on improving the nation's health, there's been a lot of conversation about nutrition, the role of better partnering with patients so that they can really make the lifestyle changes that are necessary and the like. Would anybody care to comment on that that RFI or how they're thinking about this opportunity to advise CMS about how to move our system to be more focused on a more holistic approach to care. I know there's 1,800 pages, so maybe you haven't had a chance to look at that provision.
I'll kick us off on that one.
Okay,
I think
great.
this is an area where, again, we've been very committed to this idea of team-based care and really what are the tools that practices need to make these investments. That this is fundamentally, we get down to an area around economies of scale. What is needed to be able to support the rest of the team to fully deliver on these goals? I think the issues raised in the request for information, especially around chronic disease prevention and management, I think is a really important conversation that we will start this year or continue. This certainly has been an ongoing conversation, but very much a good opportunity to look forward to next year as well, to plant some seeds about what we can work toward. I think similarly, looking with a broader aperture at other tools that are becoming available, software as a service, AI, some of these other tools that are also raised in the requests for information included in the rule. How can we better leverage some of these tools in a responsible and effective way to enhance the primary care experience for the population?
Super, thank you. Okay, we are getting towards the end of this incredible conversation. And so
And
we're
can I
going to
just-
ask for a wrap. Yeah, go ahead, Sophia.
Can I just very briefly on that and say,
Yeah.
fully agree with all that. And I think one thing, especially for the folks listening, which I imagine are many providers and physicians who might be wondering if they're going to submit comments or not. But I would say one message that I do think is very important in this RFI, in addition to everything we've talking about, it is on the MAHA agenda. I think this message from providers directly about evidence-based practices, and that we want to build payment around services that we know actually have demonstrated robust evidence behind them that are going to drive health outcomes for Medicare beneficiaries and the rest of the market is extremely important in this moment. And I know that there are some CMS folks on, and we've been carrying that message. And I just think it's an important moment for the staff. We'll be reviewing the comments to hear from stakeholders about how important evidence and evidence-based medicine and practices are, particularly in this moment.
Well, Sophia, you anticipated my last question and have answered it. So we're going to go. Yeah, no, it's absolutely perfect. We're going to go around the horn and ask each of you, what is the most important feedback that you would give to folks as they pen their letters? Some people will be writing 25, 50, or more page letters. Many of you will be writing things that are much svelter. So what is the most important thing that should be communicated from your perspective about this draft rule? How about you, Darren? Why don't you go next? And then pass it off to whoever you'd like.
I think that our hope is that CMS will hear support from across the industry, including employers. Employers are successfully offering advanced primary care. Sometimes they're doing this by contracting directly. Seniors should have the same access to this type of high quality care. If you're an employer listening, your voice will be somewhat unique in that it's not usually represented in these types of comments. And I think it could be particularly impactful. I know from speaking to staff in the admin that they do read every single one. So, even if it's just a short letter, it doesn't have to be very long. In responding to some of just voicing general support for, we applaud that CMS is focusing on advanced primary care. It's important that we get this right. This is an important tool that for delivering high quality care to our employees. That's very effective. I will hand it off to Sherry, I believe. Thanks again for having me.
Thanks, Darren. So I think that from a physician, society perspective, one of the real challenges is what I mentioned in terms of this whole impact across specialties and how it can unfortunately pit, medical societies against each other, so to speak, because of the budget neutral nature of the fee schedule. But what I think is really important in this rule is its sort of focus on helping to support and uplift primary care. And I think we all need to recognize that primary care is, we've talked about, is what is linked, has been linked in the literature, talking about evidence-based from Sophia, that it has been linked in the literature to better health outcomes, to better overall patient satisfaction, overall reduction of cost to the system, all of that. And so I think that's really what CMS seems to be intending with this rule. And so I think we should be encouraging that in our response to the rule. I do think there are a lot of nuances in there. Happy to talk about those in detail with anyone and everyone who's interested, because I do think that we need to identify any unintended consequences that we can and point those out to CMS so they can be really thoughtful about what they ultimately finalize. And so I'm happy to have those conversations.
Thanks so much, Sherry. And we're getting quick on time, so we'll do a quick Daniel and then Asaf.
Sure, 30 seconds or less. The importance of value-based care, ongoing commitment to that, team-based care, and providing different options to get there. So not a one-size-fits-all approach.
Thank you. Asaf.
Your comments matter. There's been great stuff in the chat. Please let CMS know. They have to read and formulate their general response to all the comments that they get. So your voice matters. Don't just sit on the sidelines. Let them know how this might affect your practice environment, your patients, your communities, and that's important feedback.
Thank you so much. And underscore, the comments are due by 9/12. We're going to send around an email. We're asking everyone who sends comments in to also send to PCC so we can get a sense of where the community has come down on this rule. And we look forward to receiving them. This webinar will be available on our website shortly. Thank you all.